Good afternoon, everybody. I'd like to welcome everyone to Azalea Health's industry webinar on ICD-10 unspecified codes and the upcoming October 1st grace period expiration. My name is Terry Soroki, and I will be your moderator today. I'd like to start out with some housekeeping details and let you know that this webinar will be recorded and made available along with the slides as well as our handouts. Please know that we will reserve 15 to 20 minutes at the end to answer any questions you may have. You can submit your questions at any time via the chat box in the lower right-hand corner of your screen. You will also notice in the lower right-hand portion of your screen that there are 4 handouts for reference, which will also be referred to in today's webinar. Feel free to download them now or save them later when it's more convenient. First off, we thank you for taking time out of your schedules to spend this time with us. As you know, it's always an ever-changing and busy time in the healthcare industry, and we appreciate the time you're allotting for today's webinar. We'll definitely make this time worth your while. So today we're excited to share our expertise and knowledge on ICD-10 unspecified codes and best practices you can implement past October 1st. Today, we have a member of the Azalea Health team to guide you through this transition. Doug Swords is the co-founder and vice president of revenue cycle management here at Azalea Health. Doug brings plenty of healthcare industry experience to the table, especially in revenue cycle management and performance, as well as billing and coding. So without further ado, I'd like to turn it over to Doug.
Thank you, Terry. Can you hear me okay?
Yes, we can hear you fine.
Okay, great. So I want to get started. We have a lot to cover today. I want to thank everyone for attending. We're going to go over a lot of stuff. And then what I wanted to lead off with is the precursor to this is there's 2 big changes coming in our industry very, very soon. The first one being the elimination of the grace period for using unspecified ICD-10 codes for Medicare, and then also the upcoming MIPS program, which is set to take effect in 2017. And I think we have all seen recently, I think this week, how they've kind of come out and said, well, we're going to give you, a list of options on how to participate in 2017, but it's coming. And so these 2 things are interrelated in that diagnosis coding, and more specifically finding your unspecified ICD-10 codes and how using them or becoming more specified is going to affect your reimbursement immediately on October 1st, and then also down the road with MIPS and how that's going to affect your reimbursement with the risk adjustments. So if we go to the next slide, you'll see that I found this meme. There was all kind of memes from 2015 when it first came in, and this one is like, okay, let's get ready for specificity, because you guys all remember we were thinking it was going to be Y2K all over again last year, and then it kind of went smooth. And a big part of that was the grace period was in effect for Medicare and most of the commercial payers. So it was just a matter of getting the new code set loaded, and a lot of that burden fell on the payers and the vendors to get the codes loaded and make sure their systems could take them. And then the providers had to make sure they could crosswalk and get an equivalent code. Now, a lot of those ended up being unspecified codes, but it made for a smoother transition. So now I think we need to be preparing for the specificity is going to be all the things we were afraid of last year. I think some of them may come true this year. So we have to really, really focus now on some of those rules that we thought we were going to have to focus on last year but didn't. So let's move to the next slide, and I'll talk about what we're going to go over today. And like I said, it's a lot. We're going to be answering a lot of questions, basically, that hopefully that you may have, that you may want answered. Some of these you may already know the answer to, and some of them you may not. And then I'm going to have a ton of resources for you. So one big takeaway I want you to have from this webinar is the resources themselves. And we will be making this available to you, the full webinar afterwards. So if you wanted to show it to someone else in your practice that couldn't see it, or we're going to see a lot of links to resource and web pages in here, because I did a lot of homework before this webinar started. You will be able to access all those links, so don't feel like you need to write any of the links down. Also, before I go any further, you'll see 4 handouts in the webinar toolbar. I'll reference these as we go, and there's a lot more references outside of these. You can go ahead and click on those and download them now, and as we go through some of the slides, I may reference them. But these handouts are going to be helpful to you. They're pretty broad. Some of them are like contact information for ICD-10 questions. I've also given you a link to some of the new deleted and revised ICD-10 codes for 2017 that will take effect October 1st. And then some cool, quick reference guide I found from Cigna that I thought would be useful that I wanted to kind of point out. And then the Medicare FAQs that we're actually going to go through them, but I have the full FAQs available to you because they actually answer quite a few new ICD-10 questions on there, but I'm only going to go over the ones that are the most important during this webinar. But I'm also going to touch on myths because, we're going to talk about, unspecified code, and that may lead to some denials of what you can do to prepare. But, hey, let's think long-term. What is the financial impact according to these new quality programs, mainly myths? So we're going to touch on that too. And then we're going to try to delve into what the different payers are going to do, even though that's a big unknown right now. I've got some resources for you and some words of wisdom, some advice to kind of get prepared for that. And at the very end, like I said, I got a ton of tools and resources to share with you. So let's move to the next slide, and let's talk about the grace period itself. What is it? Why is it ending? What's the impact? This is kind of like some stuff I pulled together. I've had the benefit of I've seen a lot of speakers in the last couple of months go over similar subjects, especially myths and the macro and how the coding is going to affect it. And, this is specific to Medicare, so you have to keep that in mind as we go through all this. We talk about the grace period. Some articles refer to it as like an amnesty period, and I've touched on it already, but it was basically, let's get everybody on ICD-10, and Medicare, CMS, and the AMA got together and said, okay, this is a concession, so if you go ahead and push ICD-10, and we'll take it easy on the levels of specificity, especially as it comes to denied claims and post-payment reviews. So if you read that second bullet, they've already kind of incorporated specificity into NCDs, LCDs, prior authorization requests and things like that. It was mainly the post-payment reviews that they were going to hold off on. So they basically can't, and you'll see on a later slide, they're not going to be able to audit you and hold you fully accountable or they would not during the grace period if you used an unspecified code, even if your documentation kind of was more specific than the code itself. So that's going away. So now they are going to be able to hold you accountable and deny claims for unspecified codes, and they're also going to be able to go back and start auditing you. A good, interesting fact I found and this came from CMS, that during this last year, during the grace period, utilization of unspecified codes is about 31%. So it's about a third of claims submitted had some sort of unspecified code on them. So that means we got some work to do. So let's go to the next slide. So why are we doing this? Why are they pushing this? Why was the ICD-10 codes, and then now why all of a sudden are we going to have to become more specific? It's because immediately, you're going to need it for your fee-for-service reimbursement because they're going to tighten the rules. So that's number one. You're going to want to get paid. And those of you that file claims to Medicaid or a payer that did not have a grace period, you'll understand that did immediately impact your reimbursement. You have to start thinking differently about your claim. So that's one. Two is thinking forward. This is critical for your risk adjustment for MIPS, and you're going to be scored and graded. All the eligible providers are going to be given grades, and a lot of that is going to be factored on diagnosis codes, and unspecified diagnosis codes are going to hurt you under the new risk adjustment program for MIPS. So, and then number three, it's more important now than ever. Like a lot of times it was like, let's just go with unspecified hypertension back in the ICD-9 days and roll with it. You know what I mean? We don't need to worry about it. There was no negative repercussions if we didn't get more specific, and now there will be. And this is ultimately going to affect the reimbursement. And so this is more important now than ever. And so that's why we're focusing on it. That's why we're having the webinar today. So let's keep moving. And these are the FAQs for Medicare. And later on, I'm going to show you links to all the different major payers, the commercial payers, the ICD-10 pages. Because what I did before the webinar is I went through them. I made a list of all the major payers, and I went through them to see what new updates. And there's been surprisingly little. The commercial payers have been quiet. But Medicare did take their FAQs that were already there last year when we went to ICD-10 from ICD-9, and they updated them. So they revised them about a month ago. And so I put some of the more interesting Q&As on here, and I wanted to kind of go over them, maybe help interpret them. Some of them are funny, like, the first one, when is it going to expire? And will they call them flexibilities, meaning, will we be flexible with unspecified codes? Will they be extended beyond the first? Nope. So that they answered that question. There will be no more flexibility guidance either. So they kind of, they slammed the book down on that one. So then the next page, we've got, is Medicare going to phase in a requirement to code to the absolute highest level of specificity? And they said, no, you should already be doing that, which that's not very helpful. And then they say many providers are already using more specific codes. That these flexibilities were mainly for the reviewing part, so like the post-payment audit that I mentioned on a previous slide, and also so they wouldn't deny a claim just purely based on the specificity. And these the medical review flexibilities, and that's what the way they refer to them, are going to end October 1st. So basically they're saying, hey, you're going to be more accountable not only for using more specific codes, but your documentation better support it. And this is going to be a repeating theme here, but they're saying, hey, you better, if your documentation is more specific and you're not using the code that matches it, you could get in trouble, and then vice versa. And then on the next one, it gets better. They say, will unspecified codes be allowed? They're getting right to the point here. Will unspecified codes be allowed at all after this flexibility expire? And they say yes. And this one is important. I'm going to linger here for just a minute and let you read it, and I'll just kind of discuss it. They are admitting that there are some situations where you would still use an unspecified diagnosis code. And I've seen several examples, and a lot of this is going to be like on a patient's first visit or initial encounter when you may not have all the information you need to make a specific diagnosis. And they give an example here, a diagnosis of pneumonia has been determined, but the specific type has not been determined yet. And so sometimes you may have to do additional clinical analysis or order labs or biopsies or whatever to get more specific information. So they are acknowledging that. And then later on, I'm going to kind of touch on Medicaid in particular, and especially in Georgia, and I know in most Medicaid plans did not have a grace period. So they already kind of had to address this because a lot of physicians, a lot of our clients, frankly, were upset that they were not allowed to use certain codes. And so they started to, Medicaid did anyways, become more lenient about certain unspecified codes, knowing that that a lot of physicians don't have other options at that time. So this slide is important. They're saying, yes, you still can use them, but it depends on the situation. I've seen another one, like, to be careful about laterality. Like, if it's a left or right, if it's something in the arm, that you better get specific, because that's not something that you will know that. You should know that. So they're not going to allow you to use an unspecified limb, for example, for a code that has to do with an arm or a leg or anything that's bilateral. So then if you go to the next slide, and this was one touching back on the post-payment audit. How does the end of the flexibilities, or AKA the grace period, affect audits that begin after October 1st, but are for claims with dates of service before October 1st? And if you read it, they're saying, on October 1st, they're gonna be able to go back and now hold against you the specificity, whereas during the grace period they weren't. And so I think you're still going to be okay for the period. They're not going to be able to go back and audit you on that, but now they are saying that they're going to resume those activities now, which is getting into the whole, does your code match the documentation, vice versa, are you coding to the highest level of specificity? It's the whole important behind picking the more specific codes, and not only that, but making sure it matches the documentation. So moving on, we have the ramifications. So now that we know they're still going to kind of accept them in certain situations, you may ask, well, what if I don't change anything? What if I just kind of roll with the punches and keep doing what I'm doing? What might happen to you? So, because you got to keep in mind, this is Medicare's rules, and we still don't quite know what the commercial payers are going to do yet. But here's some ramifications. This is going to look very similar to possible ramifications from last year when we were going to ICD-10. A lot of this didn't come to fruition. but maybe now we need to take it more seriously, is you may get more denials. You most certainly will get more denials, especially for Medicare. Most of you, your main payer, one of your main payers is Medicare. And then there's a lot of Medicare Advantage plans out there that are under the commercial umbrellas they're going to abide by the same rules. So increased denials means delayed cash. That's an obvious one. And then decreased productivity, because if you are getting more denials, you're going to have to stop, if you're the biller and the clinical staff, and review the chart and say, okay, what do we need to do here? Does the chart have a specific option for us to use? If not, okay, now we got to stop and talk to the clinical staff and address the issue. So that's going to slow you down. And then you're going to have some quality reporting errors. So when we start talking about MIPS and some of these, there's, all the myriad of programs that are out there now, they're going to reduce the acceptance of unspecified codes as well, or you may not be able to report them and get a satisfactory score. That's going to happen. And then you're going to get an increase, going back to Medicare, they're saying, hey, we're going to do more post-review audits, and we're going to go back and ask you for records, or we're going to be double checking that. You're going to get more of those. It's going to trigger more audit requests if you continue to use more and more unspecified codes. So those are some things just to be aware of. And moving on to the next slide, let's talk about how to prepare. So I've got a few slides here on how to prepare now, and then I'm going to talk about, how does this incorporate into MIPS, and then we'll talk about resources. But first thing you need to do, and you still got time, is to look internally. So, and this is on the clinical side and on the billing side. So let's first find out, how bad is it? How many are we using a lot of unspecified codes? Remember earlier I said 31% is the current rate. So, we did some analysis for revenue cycle management for some of our customers and found some that were 50% and some that were 5%. So you want to first start with, well, how often am I using them? And so you need to go to your software. In Azalea, we have an unspecified ICD-10 report that you can run, because we knew that was going to be something that would be a focus, that is basically all the unspecified codes listed by frequency. So you can see, what are my top 20 most used. So we usually recommend find your top 20 most used. And then if you're a group practice or multi-provider, you want to get it broken down by provider, because you may have certain providers that use unspecified codes more than others. And then, identify patterns or trends. So is it certain conditions that are being used the most? Are you using an unspecified diabetes code more often, or anemia? We're going to talk about chronic conditions in a little bit, but those are the ones that are even more important. If you're using a unspecified chronic diagnosis codes on a repetitive basis, you may want to focus on those first. And then also, if you're still using like a paper, super bill, rounding slip, face sheet, you're going to want to take a look at that too. And you probably did that last year already, but there may still be some unspecified codes on there, ICD-10 codes, that now, whereas you could have left them on there for the grace period, you may want to take another look at them. And this may be the point where you say, wow, I'm going to have a 5-page, paper super bill. Maybe I should go in a different direction or become creative on how you handle that. Most software systems now have quick picks or internal super bills where you can put your favorites in, and I'll mention that on a later slide as well. But that is going to be something you want to consider. And then the documentation is more important than ever. Like all the coding agencies, if you go to HEMA, you go to AATC, they're all pushing their clinical documentation programs, the clinical documentation certifications, because they know that it's going to be huge now to be able to tie your codes back to the documentation and make sure that the documentation backs up the codes, that it's going to be a big emphasis. So the first thing you need to do is make sure that if they are using unspecified codes, let's pull a couple of the charts up and see, well, could it have been more specific based on the documentation? If yes, then you should be able to sit there and figure out maybe what the newer codes should be or what the more specific codes should be. If not, then that's when you have to go back and circle back around with the clinical staff and talk about that more. Like, how do we make, if it's a template issue, if it's a documentation issue, what is it exactly that could be tweaked or modified to make the documentation more specific, so that way it backs up the more specific codes. And then on the next slide, that's the initial review. Ask your software vendor. I'm going to talk about EMR, but internally, and this is in Azalea, we have flags built. We went, and you could basically run, if you have, Medicare makes it available to you, a complete download of the ICD-10 database of all the codes. And they all have either the word unspecified or an UN SP abbreviation, and you could search that and find them all. And what we've done in our software, and in other softwares I've seen this too, where they're flagging them. This is basically bringing it to your attention. So during your day-to-day, like right now, if you're in the system and you see this, you may become alarmed. Why is that red? It's unspecified. I need to be wary of that, especially after October 1st. And these are screenshots from Azalea. The first one is from the encounter screen. So it's on the billing side. So the billers would see that, and it would bring to their attention immediately. They would start thinking, what are the payer rules? Do I need to review the chart real quick before I send this claim? And then the bottom image is on the clinical side. You're going to want to see it on both. And you may want to ask your vendor, hey, do you guys have anything in the works that are either going to flag or a way for me to sort, filter, flag, or otherwise identify an unspecified code in the software? Because you see here, it gives you the definition, but a lot of them, maybe the definition is long and it's truncated and you're not seeing the word unspecified, so you may not know right away. So be looking for that. That's just a couple shots I wanted to show you. And then after this, let's talk about the billing staff. If we go to the next slide, what do you need to do with your claims? You know, what do you need to do with how do you prepare from the billing staff? So what we recommend is let's take a list. Let's start by creating a log. Let's take your top 10 or 15 payers. You know, you already know, like Medicaid probably doesn't have a grace period, so you already know what they are. And then you got Medicare, we know what's happening with them. But then you've got Aetna, Cigna, United Healthcare, whoever the commercial carriers are in your area, in your state. Let's list them, and then let's also keep up with, and I've got these links for you already. I've already done this homework for you. You know, let's make note, bookmark their ICD-10 resource page and resources. Like you'll see Cigna and a lot of them have given you some really useful resources that you could use depending on your specialty. Let's make note of that, and then let's start keeping notes, because you're going to continue to file claims after the first, but you don't know, and United Healthcare has purposely been glib about what they're going to do with specificity. A lot of the payers have said, well, you know, we're going to do what Medicare does, which is hint, hint, you're probably going to see some denials there. So if you keep a log, especially if you have multiple billers in your office, it's going to help you, especially, you know, the folks that are managing denials, it's going to help them relay the information back to your coding and billing staff. So that way, the minute we realize that United Healthcare or Aetna, whoever it is now going to be just as hard about unspecified codes as Medicaid is, you can relay that to the front coding staff, and the faster you can do that, the quicker they can stop and say, okay, before I file this next claim, I now know that they're going to deny claims based on specificity because we've already gotten some denials and that's been relayed to me and I could see it on this log. So let's create a list. This way it's not just one person in the office that knows it, but maybe hasn't shared it with everybody else. And then keep up with the denied code. CO 167 is the standard code that we've seen from the Medicaid plans that are not covering. And you see it says this code is not covered. Very basic. There are other ones out there, and we may see them add a new adjustment group code or remark code that's more specific about the level of specificity, but that's what we're seeing. And also look internally, do you have a way to see those codes in the system? Because you may want to, at the end of October, for example, do a look back on yourself and see, well, how many denials did I get for CO 167 or whatever denial codes that you're seeing from your payers? Because you probably would, and I would recommend doing a look back on yourself. So that way, at the end of the month, at the end of October, November, you can go back and do a summary of denials, and then you could get like a high-level view of your commercial payers and even Medicare and see, well, how bad is it? You know, how many claims did I have denied? You know, which ones do we need? So that way you can keep your log updated of what the payers are doing. How are they reacting to unspecified codes if you happen to use one? And then you also want to keep up with crossover and secondary claims. We found that with Medicaid, you know, if they got a secondary claim and an unspecified code was sent to the primary carrier, by the time it crossed to them, they were going to deny it, and they did deny it for unspecified code. So that means that, and if you know that, and you've got that listed on your log, or if you've otherwise recorded that, you would also have to think twice about sending a claim to a primary carrier if the secondary carrier, Medicaid or Medicare, if you know they're not going to take that unspecified code. So you may be dealing with a commercial payer that's still maybe being lenient, but the secondary payer is not. So that will affect that secondary. You might get your primary balance might get paid, and that may be fine with you, but your secondary balance may be at risk if there's an unspecified code there. And then again, I've mentioned you've got to communicate, with the other billing staff and the clinical staff, because again, this is going to be, the whole office is going to need to be involved with this. So that's step one. That's a lot for step one. So step two is let's look at the software now. We talked about the billing staff and how you're going to prepare to get ready for the payers and how they're going to react. But just look at the places in the software. That's what I did when I sat down. Okay, where in the software are these codes going to be, and where could they potentially be pulled from? So you've got, in most systems, you've got templates that you can preload codes behind them. So let's go through your templates. Are there any with unspecified codes preloaded? And if so, do you want to take a closer look at the documentation in that template to modify it to be more specific, or maybe to prompt you to pick a more specific code? And so that's step one. Step two is consider a patient's problem history and previous diagnosis information is there and may be pulled to current visit. And so this is where the clinical staff has to be wary. And that's on the previous slide, I showed a screenshot where we were going to display, and we are displaying all unspecified codes in the system is red. And that's basically, this is a big part of that. If I'm pulling up a chart and I'm pulling in diagnosis codes or reviewing diagnosis codes from a problem history or their last visit, before I pull those forward and adopt them to this visit, I may want to make sure, okay, are these unspecified codes that I've been using for the last year on this diabetic patient? Now this visit, I need to start getting more specific, and that you want to be careful when you are doing, reviewing problem history and the previous chart information. Also, most software systems have favorites, diagnosis quick picks, or in some cases electronic super bills where you have your codes pre-built in there. And that's another place that you're going to want to go ahead and review for unspecified codes. And that's basically, and then you get your vendor involved if you need to, especially going back to the first slide about, getting your frequency list. If they don't have a report available, they may could help you find the frequency list by provider. So part three of best practices and how to prepare is let's get ready for the future. So this year and in a couple of weeks, we're going to get a lot of new ICD-10 codes. And I didn't know this until a few months ago, but there was a code freeze going on. And this was going on for several years. And the idea was, hey, let's not add a whole ton of new codes because until everybody gets on. So we want all the providers in the United States to get on ICD-10, and then we could start updating on an annual basis. But let's kind of freeze them. So they called it a partial code freeze. So for about a 3-year period, they didn't really do a lot of updates to the code set. But now in October, they are. So they're going to open the floodgates apparently, and you're going to have about 1,900 or 2,000 brand new ICD-10 codes added to the data set. And there are also going to be some revised and deleted codes as well. So you got to prepare for that. One of the handouts that you have is the list of new revised deleted codes. So make sure you download that and take a look at it. Especially, we all know that not every code in the code set applies to you and your specialty. So you may want to review it, highlight the ones that you do use specifically in your practice on a regular basis. And then, be prepared for the future and keep this in mind. This is, and this is something that I've been reminded by several other speakers that I've seen when they talk about these new programs. Is you're going to be, reviewed, they do a look back period, and they're going to compare you against your peers and against yourself. And this all goes back to your diagnosis coding as well. So, at the end of 2016, they're going to look back at the year, and especially next year when MIPS and those programs, and depending on how you participate, there's going to be the look back period, and they're going to go look back and see what you did, and then that's going to affect your reimbursement. I think usually about 2 years. There's usually a 2-year gap in how that works. So depending on how you score or how you do in 2017, it's going to affect your reimbursement in 2019. So you have to keep that in mind. And then you have to be prepared to be consistent with your coding to mitigate year-over-year statistical reporting inconsistencies. And we're going to touch on that here in a second when we talk about how ICD-10 affects your MIPS and future reimbursements. So let's spend a few slides talking about MIPS. Now I could spend another hour just talking about MIPS, and it's a very complicated program, and it's not even finalized yet. We did find out recently that we're going to get several options on how we can participate, and we already know that we could do an advanced alternative payment model or MIPS. There's not a lot of advanced alternative payment models out there, So most of us will be participating or subject to the MIPS guidelines. But here's just some interesting facts to keep in mind to set the stage, that we're not getting rid of fee for service, but you're going to have a positive or negative swing, and they call them adjustments to your fee for service based on your performance. And again, ICD-10, unspecified codes, all that is going to be factored in. And they also are saying, hey, we expect this program to be revenue neutral, meaning that we expect enough people to fail or have bad scores to where their negative adjustments will offset any positive payments we would pay. So they expect everything to net out. So they're thinking that a lot of people are going to get negative adjustments in this thing. But that, again, if you read this, you're going to be measured against your peers, not an absolute standard. So it's going to be interesting to see how that plays out. And then to remember, the overarching goal of MIPS is to achieve better quality care and but with less expensive. So they're trying to do both. How do we increase the quality cost? And then the quality and resource components make up 60% of your score. So a big chunk of how you're going to be graded is based on, quality and cost. And that is being based, a lot of that, on your diagnosis coding. And then I put it, this is a link here, but this is the best one. I've been, several other speakers and programs I've been to. It's from SA Ignite. They're basically a firm that focuses on consulting in these areas, and they have a really good FAQ about MIPS. And on that same website, there's and the only one I've found online is a financial calculator. It's an Excel spreadsheet that you can play with and see how, if you manipulate the spreadsheet, it'll show you what your risk adjustment scores would be in your positive or negative adjustments in future years. So that's a really cool tool. I wanted to point it out. And again, this you will be able to click on that and get that later when we make the slides available. So then the next slide, this is an image of those positive and negative swings over the years. So this is the 2-year gap I talked about. So performance year 2017 is going to affect your reimbursement in 2019, and so on and so forth. So you could look at a positive or negative 4% swing in reimbursement based on your scores. And hopefully you guys have seen or have watched or plan on watching and read about the MIPS program and how all the components. It is complicated and it's not finalized, but you need to understand it as best that you can to see how this is going to affect your reimbursement. But this is kind of the swing, and then you can also get a multiplier of 3 times those rates for exceptional performance bonus. And then there's other points that, if you look on the right, that if you're positive on a recurring basis on the positive side, you can get increasing revenues from that as well. So I wanted to point that out. So ICD-10, how does that factor in to MIPS? So you've got more risk adjustments, and don't get overwhelmed, because and this kind of goes back to last year. You've got all these new codes, and there's so many more new codes, but don't forget that most of the codes, depending on your specialty, you're not going to use. You're only going to be focusing on the code set for your specialty or your group. So then there's also a warning: do not use GEMS and just standard crosswalking tools as your only tool for ICD-10 coding. You could get trapped, and you could get into the habit of using the wrong code on a consistent basis, and that could hurt you. And it might be 2 years before you realize that you've been using it wrong because you're relying on a crosswalk tool as your only source. And then I've already kind of mentioned this, but you're going to be graded on 2 composite scores, cost and quality. And depending on your scores there, you're going to either be penalized or rewarded. So on the next slide, and these are things that I recommend for you to do and to focus on when you're looking at your unspecified codes. And this is something that I've seen repeated in a lot of the materials. And this is something that I can say that is across the board for all specialties. It says, let's focus on chronic conditions. You're going to be assigned those scores, and you're going to have, if any of you have heard of, and I'm not going to delve into it too deeply, the HCCs, and a lot of the other underlying scoring mechanisms that like Medicare Advantage plans use now to create scores for patients. Diagnosis codes are going to have scores of risk factor scores associated with them. So there's some tricks and things to keep in mind when you're coding and when trying to get more specific that are going to increase those scores and therefore reflect you as a provider as providing a higher quality care but at a lower cost. And you can make some really simple mistakes that are going to lower your scores or hurt you. But the first one that I recommend is to focus on your chronic conditions. And so any of you that have maybe looked at the chronic care management program have maybe looked at a list of the top 20 chronic conditions or the ones covered under that program. Let's look at that program and then look at the subset, the family of codes for those chronic conditions, and let's focus on being as specific as possible on those, because those are the ones where you're going to get the highest risk factor scores, because those are the ones that are driving up the cost the most to Medicare. And that's where, I can't remember the stat, but it's something like 80% of the spending is on these chronic conditions. And so that's where they're focusing on. So you probably, depending on the specialty of your practice, are treating people with high blood pressure, heart disease, COPD, you know, arthritis, osteoporosis, depression, I mean, anemia. I mean, if you go all the way to the top 20, you'll see them. So let's focus on those, and let's make sure that we're as specific as possible on those chronic conditions so you're going to get the more bang for your buck. And then if we go to the next slide, here's a couple things that you have to remember, and let's make sure we're using these codes and that we're backing these up with our documentation. These are going to help you with your scores on the MIPS program if you can incorporate this and use these on a repetitive basis. But one is, remember to use combination codes for multiple chronic conditions and avoid coding them with two separate codes. And here's a couple. The hypertension one is a big one because that's chronic, and that's one of the big ones, if not the biggest. You have hypertensive heart disease with heart failure with chronic kidney disease. And so let's use I13.10 instead of I10 plus whatever the stage 4 chronic kidney disease code is. You'll actually score overall in your composite score under the MIPS program if you use the combined codes. You need to be familiar with that. That's why I say, going back to the previous slide, let's identify the chronic conditions that you treat the most, and then let's look at the family. Are there any combo codes in there? And if there are, let's start using the combo codes. Let's put those on our super bills and our quick pick list. Make sure that they're right in front of the clinician so they know, oh, I can use this code and not have to use two separate codes for patients with hypertension and chronic kidney disease. Two other big ones that you want to use and incorporate, and I know a lot of you are familiar with these, is for long-term use of medication codes and non-compliance codes. Non-compliance is a big deal and will become and continue to be a big deal for you in your score. If you have a non-compliant patient, you need to be using these codes. And these are just examples. This is not the entire family. These are just some commonly used recommended ones, and I think I accidentally repeated the same code twice there by accident. I apologize. Under long-term use codes, they're not both D79.4. I think one of them might be 0.2 or something like that. But these are more common ones. So long-term use of insulin, long-term use of anticoagulant. You know, you may not be seeing the patient that day for that in particular, but if they're on those, you have to put that on the claim because that is factoring into your medical decision making. So you need to include those on the code on the encounter, and they need to be on the claim. And so that way you get credit for it because it's going to, like I said, increase your risk factor scores, and it's going to help your composite scores. You have to remember to use these. There's a lot of, especially with Medicare, and again, a lot of this is big. This is Medicare program. A lot of your patients are on insulin or on anticoagulants. So let's include that in their problem history. Let's make sure we're using those codes. Also, non-compliance codes, to get back to that, you know, if you have people that are being non-compliant, a lot of the complaints that I hear from the physician community is, this isn't fair, I have non-compliant patients, I can't make them compliant. It's to your advantage to use the non-compliance codes and be familiar with them and make sure that you're reporting them. So that will also help you on your scores. And so I just put a couple of examples there. The second one, non-compliance with medication regimen. And if you look at a code book or in some of the free resources I'm about to show you, you'll see that they give you a lot of different variations of that explains it more. And that Z91.14 I know would be commonly used for a lot of our providers. For patients that either maybe just don't know what to do with their medications, or they forget, or just not being non-compliant on purpose, use those codes on your clients and use them repetitively. Include them on your super bills and your quick pick list. Okay, so the next slide. So let's talk about resources for a little bit, and then hopefully we'll have time for Q&A. I'm actually going to spend a lot of time on resources, and again, you don't need to write these down. But I did a lot of homework. I went to all the major payer sites to see, what are they doing with ICD-10 with the grace period about to end. And I will tell you what, 90% of them have not made hardly any changes since they put their original ICD-10 material last year. But some of them have added more. And some of the last year materials are still relevant. Like I said, a lot of them are guides on how to get more specific that maybe we didn't pay attention to last year because we weren't forced to be more specific. But Medicare in particular has a lot of new ones. The FAQs, I did screenshots earlier, and it's a handout, so you have it. But they also have a road to ICD-10. It took me a while to find this one because they have a standard ICD-10 page, which is that first link. And that's where you can find all the code sets and everything like that. But they also have a separate page called Road to ICD-10. And within there, you're going to see a lot of specialty references and quick references that are going to be super useful to you depending on your specialty. Because some of them, like the specialty references, the 35-page document, kind of advising you with different case examples and giving you families of codes, especially for those chronic conditions that we mentioned earlier. And then also there's clarifying questions. There's a joint announcement and things that I think that you should read that will help you prepare. So then on the next slide, rather than jump and clicking on all these, I figured I'd put some screenshots on here. So if we go to the next one, you'll see the Road to ICD-10 website. And you'll see on the left there, you've got the quick references. That one alone is going to give you links to a lot of the different AAPC, AHIMA, other industry web pages and their ICD-10 pages. And then under medical cases, if we go to the next slide, you'll see under medical cases they have specialty references. And you'll see there I've clicked on the expand button for internal medicine. But if you click on those download the guide, the common codes, the primer, and the scenarios, there's a really, really useful information about how to get more specific. And they do focus on those chronic conditions that I talked about earlier, give you the family of codes, give you some examples. So that even though like the internal medicine guide, I think it's 35 pages long, if that's what your practice and specialty is, it's worth downloading that guide, having it, and reading through it, even if you're billing or clinical staff, to get an idea of what, because this is coming from Medicare. Medicare prepared these documents. So you could also use these as your guide for other commercial payers because they are more likely than not going to follow suit with Medicare. So I wanted to kind of show you this, and when I came across this, I thought it was very, very helpful. So I wanted to kind of show you that and make sure that you check that out, and that's a link to it at the top there. So in the next slide, with Medicaid, there's a ton of different, every state with Medicaid is different. And don't forget to, Terry, if you're listening to the next slide. Yeah, there we go. So I just put, go back one. So I just put, this is Georgia, because I know a lot of our listeners are in Georgia, and that's the one that they've been very, very helpful. This is HP, who's our contractor for Georgia. But then with the Department of Community Health have been pretty open about how they're going to manage and deny claims for specificity. And I want to spend a moment here to remind you that Medicaid is probably your only payer, one of the few that you're dealing with now that did not have a grace period. So we need to remember the lessons learned from them, because those are probably going to be similar situations that we're going to run into with Medicare, because it is CMS, and then the commercial payers are, like I said, they're going to follow suit. But the awesome thing that Georgia Medicaid did, after they got a lot of pushback, because they were denying a lot of claims, if there was any sort of unspecified code on the claim, whether it was the second, third, fourth pointed code, it was creating a denial. So they released a list, and if you read here, and you could read these later on the slides too, they had a committee sit down and review all 15,000 unspecified diagnosis codes, and they went and plucked out a few that they said they would accept because they realized there might be not enough clinical documentation. Going back to the examples earlier about, if someone comes in with an infection and you don't know what the agent is, or the pneumonia one where you don't know the cause of the pneumonia yet. They pulled a lot of those off, and they basically have now provided us with a list of codes that will, for sure, trigger a rejection, unspecified. So I wanted to point this out, and we can make this available to you if you want it, or if you go to the next slide, I'll kind of show you where it is on the Georgia Medicaid site. If HP is your carrier for another state, they probably have a similar format on their website, and they also probably have a banner messages or provider notices page. But on there, and if you go to the next slide, you'll see where I've kind of highlighted it there. They've given a list, and they updated it in July, and it looks like they've been doing it every quarter. Go back one. It looks like they're doing it every quarter. And so that was the message on the previous slide. And this one is like, here's the Excel file, and you download this file, and here's and they're very clear. If you read it, it says ICD-10 unspecified code set to deny. So I want everybody, this is very important, I think, and we've been using this as a tool internally because they've already kind of done the work. They've been doing this for a year, and they've already gotten a ton of pushback from physicians on, hey, I can't use a more specific code because of X, Y, Z. So they've already kind of got a list of ones. So we, like for example, I was meeting with a client the other day, and it was a ophthalmology practice, and they had a particular M code that was unspecified that they were saying, well, I can't. How am I supposed to get more specific because of the situation? I don't know. So sure enough, we pulled up this list for Medicaid, and it was not on the list, meaning Medicaid had already crossed that bridge, and they already realized that particular code may be your only option. So that set the provider at ease, saying, well, Medicaid already is going to accept this code, and I would be willing to bet that Medicare and some of the other commercial payers would probably draw the same conclusion. So that's why I think even if you're not in Georgia, getting your hands on this code, and you don't have to have a login to the Georgia Medicaid site to get that. And I've provided the resource link previously, but you can go there just from anywhere and get that Excel sheet if your state Medicaid plan doesn't provide it, because it is helpful, and they've already done their homework on, and they've already gotten pushback from the providers on certain codes that have to be allowed. So that is a very, very useful resource. And like I said, even though it's Georgia, I would recommend you downloading it if you don't have one for your state. So then, what are the other payers doing? So here's the links, and again, you'll have access to this, but I went out and found all the major payers and their ICD-10 resource pages. Some of them have more than others, like Aetna just has a single place where they do ICD-10 and MPI updates all on one page. Anthem, Cigna has a lot of good tools, and United Healthcare. Also keep in mind LCDs, NCDs for Medicare, but then you also have United Healthcare has their own set of reimbursement policies, and so does Blue Shield Anthem. You're going to want to check those as well to make sure that, and I think they already did this, like on the earlier slide I talked about how NCDs and LCDs were kind of already updated last year, and they were already put in with the codes, the specific codes they wanted. So I looked again, and I didn't see any big changes to those for the LCDs, NCDs for October 1st of this year. But you never know what the commercial payers are going to do. They may sneak in some new policies, and they haven't so far. From when I went through a lot of the United Healthcare reimbursement policies that were specific to medical procedures, they hadn't changed since October 2015. But so take a look at these, and then let's go to the next slide. And this is one of the handouts, but I really like this one because it touches on those chronic conditions that I talked that you should really focus on. And Cigna on the next slide has, and I couldn't get the whole thing, but if you downloaded it from the handouts, you'll see that it's a list, it's a quick reference code guide. And it's basically they took all the chronic conditions. And I don't know, Terry, if you can hear me, but we need to switch up one slide to the Cigna HealthSpring image. But there it is. So this is how it starts, but it's several pages long, and it has all the major codes. So this kind of already has done the homework for you. It gives you the unspecific code, but it also gives you the full family and everything. And I thought this was a useful tool for you to go ahead and have. That way, when you are reviewing your own codes, to say, well, what are the chronic conditions I see the most, and what does the family look like? Here's you a nice tool for it. Cigna's already kind of put it together for you. A lot of the other ones have too. And back on the Medicare slide where they have the specialty-specific reference information, they have this similar type of charts for you as well that are more specialty-specific. But this one was kind of overarching, multi-specialty specific quick reference guide that I really like. So then on the next slide, I've got a few more payer links here, Humana, Coventry, TRICARE. And then a good quote I found when I was doing my research, Blue Shield of South Carolina. I found this interesting. He says they don't want to create, their goal, I guess he was trying to ease anybody's concerns about the lack of communication from the commercial payers. He says that they don't want to create any more disruption than necessary, so physicians can expect a gradual increase in specificity requirements. So that was the first I'd heard of that, and that did come from the Blue Shield payer. So I wouldn't be surprised if you didn't see some increased leniency even after October 1st from your commercial payers, but then to have it ramp up over time, maybe in an even different fashion from Medicare. So I threw that quote on there for you to have in addition to those other links. So then the next one is Medicare. I wanted to point this one to you in particular. This is one of the ones that I just found was really nice, helpful to have. There's a lot of stuff here. So this is the Medicare site where you can actually download the code sets with the full codes, the descriptions, and there's a lot of stuff here like GEMS mappings, that a lot of CSV files and things that you may not care about. This is basically the equivalent of having the ICD-10 code book at your fingertips. And the one in particular that is good is the code descriptions in tabular order, I believe, is the one that's basically the code book in a PDF format that you're going to want to download and have. And so I wanted to point this one out because this comes from Medicare. And this every year, like that's the 2017 code set. It's taking effect if you read October 1st. But every year they put the new code sets there in addition to the new ones. And so this is a good one to bookmark that. And so then the next slide, and a lot of you are already aware of this, but it's amazing how much free coding information is out there. This one you definitely want to bookmark, especially if you're a biller, ICD10data.com. And look at all this information they have here. You know, one of the handouts I gave you is a list of the new, revised, and deleted. So there they are right there. You see the link. They've given them to you for free on this website, and they have them every year. You can always come back here and check. You don't have to wait for the next Azalea webinar on codes to get the next code set. They pull them and they aggregate all this information here. And you also see under the indexes down there, those codes, the tables, that was from the slide we just looked at. They're also pulling them from there and making them available to you. So really, I would recommend just make sure you bookmark this site because you can look up the codes. And what's really cool about this site in particular is they give you a lot more. Like once you click on any of them and start looking up the codes. Like I have we've ordered some new, pretty advanced ICD-10 code books. And I know a lot of the code books are giving you information about, you know, this is specific to a male or a female, or this is pediatric or newborn. Those little indicators are on this website too. So really, the only time you need a book is if you're going to sit down to take a certification exam, and you can bring it in with you. But you should be able to get all the information for free that you would need to do your ICD-10 coding using these online free resources. And then on the next page, this is kind of like, this is the same website, but this is basically, that's the code book. They break it down. You click on those links and you can drill down into the code set. And they also have a search tool. And it gives you all the includes, excludes, code first information that you get out of the book. And it's very, very helpful information, and I definitely recommend it. On the next slide, some iPhone apps. The first one is free, and it's really, really good. And then if you want to pay, that second one is probably one of the best of the ones that you have to pay money for. So definitely go ahead and download those to help you. And I'm not sure, I have an iPhone, I'm pretty sure they're available on the Android as well. But I wanted to kind of make those available to you. There's a ton of them out there. And I know I was clicking through the ICD-10 apps in the App Store, and again, a lot of them had not been updated since 2015. So there's 20 of them out that 80% of them really weren't worth downloading, even though they were free, because they hadn't been updated since last year, whereas this one's actually called ICD-10 2017 Consultant, and it's free. So that one's a good one. And that's pretty much it. And we've covered a lot, and I know maybe I didn't spend a lot of detail in any one particular area, but a big part of this is kind of just me giving you the why, what's going on, why it's important, what you can do to get ready, and then also not to forget to disaggregate these resources, and let's get prepared. Let's do our homework. So I think now we can open it up for questions, and I think there's some additional housekeeping items to go over before we close.
Okay, thanks, Doug. Yes, now we'll spend some time answering those questions. Again, please use the chat box on your screen to forward those questions to us. Please also know that if your questions tend to be more specific, we would be happy to follow up with you one-on-one offline. Again, remember to download the handouts, the 4 handouts in the lower right-hand corner of your screen. And again, at the end of the end of the webinar, we'll have a slide that will also have an email address on it. So if you wanted to jot down any questions to contact us offline, we'd be happy to help you out there as well. So let's look at some of the questions here. The first question, Doug, will the commercial plans, for example, Blue Cross, Aetna, Cigna, Humana, etc., also deny the unspecified codes as of October 1?
Well, that's a big unknown right now, and we kind of touched on that, and that's why I recommend you getting those links and keeping an eye on their ICD-10 pages. A trick, and I'm glad that was mentioned, because you'll notice with Medicare, they didn't update a whole lot of stuff on their ICD-10 page. It's a lot of stale information from last year, but the one thing they did update was their FAQs, and I noticed the same with some of the other ones, like Aetna, for example. Nothing really much had changed on their ICD-10 page, but they had modified their FAQs. So that may be one of the first places you want to check to see if a commercial payer has made any changes, official changes, to whether or not they're going to deny. I would imagine, my guess will be that you will see them, but based on that quote that I showed from Blue Shield, you may see some leniency more so from a commercial payer in the beginning than Medicare, but then expect that to kind of phase and ramp over time to where they become more harsh.
Okay, Doug, here's another question. And this must be coming from someone familiar with our own software, but what is the unspecified ICD-10 code report in Azalea called? He's not able to locate it.
I'm sorry. If you go to reports, and if you just, in the search bar at the top, just type in the word unspecified in the search tool, and you should find it. It's the only one in there that's called that. And you'll notice when you run it, it's going to give you the option if you want to just run it practice-wide, or if you want to have it subtotal by provider, by location, or insurance class, which I would recommend you run it multiple ways, especially by insurance class, because you want to see if you have a high rate of usage on unspecified codes for Medicare, then you should be alarmed.
Okay, and here's another one. Let's see. We code physician charges for hospital stays since the providers are often documenting from the patient's history and do not have access to the patient's complete record or knowledge of the specific diagnosis. Is there going to be more flexibility for these types of visits?
Unfortunately not, and you see in Medicare's FAQs, they were pretty clear about that. That was actually one of the questions was, is there going to be any additional flexibility for other circumstances? And they were like, no, there's not. So, and like I said, it's going to be very, very similar if you bill to Medicaid now. They pretty much take no prisoners, and if you're appointing an unspecified code at any of the CPTs, they're going to reject it. There's tricks you can do, depending on how many codes you have. If you have 4 diagnosis codes and the 4th code is the one that's pointed and it's unspecified, you can unpoint that. You would not want to unpoint a principal diagnosis or anything that is the sole covering diagnosis, but there are things that you can do, but I don't think they're going to be lenient with that.
Okay, here's another one, Doug. How will the use of unspecified codes differ between hospital versus clinic claims, critical access and rural health versus PPS hospitals and non-rural health clinics?
That's a good question. Like when I was going through my research, I noticed the DRG information for the hospitals is being handled differently, and I didn't spend hardly any time reviewing how the DRG reimbursement would be affected by unspecified codes. But I do know that Medicare. So if you're a rural health clinic and you're filing claims for Part A and Part B, you would still need to focus on that. It's going to affect both claim sets, and that would be for critical access to or any of the quasi that are filing claims in a UB in a 1500 format for like a clinic.
Okay, another one. What exactly is GEMS, G-E-M-S, the acronym GEMS?
It's the general equivalency mappings, and they originated from Medicare when they were converting ICD-9 to ICD-10. So it's basically saying if I use 401.9 for ICD-9, that it generally maps to I-10 for ICD-10. So they had, I guess, a group of people sit down and map the code sets together, and they call them generally equivalency mappings or GEMS, and they have them every year because with the ICD-10 codes changing every year, it may affect the crosswalking tool. So, even though we're a year in now, most software systems still will crosswalk whether it's one code to another and vice versa. You can code back from 10 to a 9. Sometimes that's helpful, reverse mapping to see what it equated to back in ICD-9 if you're still more familiar with ICD-9 codes. And also you can do it like an alpha, so if you want to just search by a word, keyword, and then crosswalk that, the gems would be useful for that.
Here's a more of a logistics question here, or a reality question. Do you think it's worth paying the money for the big ICD-10 book versus the free links or info we can get online or via an app for a few bucks?
If you're me, I don't think it's necessary to have the books. If you have a big billing staff, you might want to have one around. There might be a couple things in the book that you can't get online, but like I said, I went through myself, and a lot of the little tools that are in the advanced ICD-10 book around, gender specific, a lot of the includes, excludes, it's all on that website. It's almost like the people at that website bought a book and then went and just copied it all onto the website. So it's there. And again, if you plan on ever getting certified, you'll want a book to take with you to the exam. So, but if you're just by yourself, if you're, some people just like the books, so that's a preference thing too. They're more comfortable. They're used to using books because that's the way they've been doing it, and they can just do it faster. But a lot of people just grew up using just Googling the information about, and half the time when you Google a code, it takes you to that ICD10data.com website anyway. So I would just, if it were me, I wouldn't bother buying a book unless I was going to go get certified.
Another question, Doug, here. Let's see. What about when it comes to acute care codes, like allergic rhinitis, sorry about that, or URIs? What will happen when it comes to those acute care codes?
Well, I mean, the same rules will apply. So look at the code itself. Is it unspecified or not? And if it is an unspecified, per definition in the code book or on the coding materials, then, can you get a more specific code? If not, and this is going to happen a lot for acute situations, you may not know, certain things, and if it's the first visit. So like on that Medicare FAQ that we looked at, they said there are going to be some situations where, they'll take an unspecified code, especially if a certain infectious agent is not known right away, and that may be an acute situation. So you may, in a lot of acute situations, be able to use more unspecified codes than normal because you just don't have enough information. But they all kind of also point out that on that second and third visit, you better get more specific because you should, at that point, have more information available to you.
Okay, and then we have one here. After October 1st, will it be possible to correct the codes and resubmit for proper payment?
Yeah, so you will always, if I'm understanding the question correctly, if you get like a denial because the code was invalid, and we can do that now, like if you are filing claims to Georgia Medicaid or any Medicaid plan or plan that does not take unspecified, they will allow you to send a corrected claim. You'd have to go back, and that goes back to the slide where I talked about declining productivity, because you will have to go back and kind of read your chart, and hopefully the chart's specific enough for you to make a change on the code. If not, you'll have to go back to the clinician and talk to them about it. But yeah, you will be able to correct and resubmit or appeal. So if it's a situation where, and this is what I think Georgia Medicaid went through, had a lot of appeals come in, especially for certain diagnosis codes from the provider that says, hey, I can't get more specific and here's why. So if you do have to write one of those types of appeals, go ahead and save it as a template, because you may have to use it pretty often to appeal and explain medical necessity and why a more specific code is not usable at the time.
Okay, and I think we just have about one more here. Just a couple of questions coming in that as far as, yes, you'll get a copy of the slides, you'll get a copy of the webinar. All of the links that we showed in the slides will be in the version that you get, so you have all kinds of time to write those down. There'll be active links as well that will drive you to other sites for additional information. And let me see if there's one more question. Oh, here's one. If we use an unspecified code after October 1st, is there a case where that would be acceptable.
Yes, so, and that's why on the handouts there's in the Medicare FAQ they talk about those situations, and they give the example of pneumonia, and if it's a first visit you may not know what type at that time until you run some additional tests. So if the information is not immediately known to you, and usually this is on first encounter or initial visits, that they will accept them. And that's why I also strongly encourage you to download or find your state Medicaid, if they do provide a list of unspecified codes, that will 100% trigger a rejection, because you could use that to plug in codes to see if it would pay or not under that program, and it would give you a good idea if other programs would accept that one or not. I would imagine that a lot of the codes, like I see pneumonia a lot, infections a lot, repeated as codes that would be acceptable, because more often than not you need more information to get more specific.
Okay, Doug, I think that's about all the questions right now. Just want to say, again, thanks everybody. On behalf of the entire Azalea Health team, especially Doug and myself, we sincerely thank you for attending and participating in today's Azalea Health industry webinar. Again, the webinar will be made available to you via our website as well as email. We'll include the slides and the handouts. We hope that you can join us next month to learn more about a hot topic right now: why telehealth, why now? If you need further assistance, you can jot down either our phone number from this slide or our email address to reach us directly. We're happy to help. And again, hope you can join us for future webinars. Thanks again, and we wish everyone a great day.